So welcome everyone to the Gluten Intolerance Group event, Getting a Celiac Disease or Gluten Sensitivity Diagnosis. My name is Lola O'Rourke. I'm Education Coordinator here at the Gluten Intolerance Group, and I'm also a registered dietitian. I'll be co-moderating with Eliza, who you've been hearing from. We have a wonderful panel of experts here to discuss various aspects of this topic. We're very lucky to have them, and I will introduce them shortly. But first, I want to say a few words about the Gluten Intolerance Group for those who may not be familiar. The Gluten Intolerance Group, which is also known as GIG, has been in existence for 47 years now. And our mission is to make life easier for everyone living gluten-free. There are really three basic pillars to how we accomplish that. The first is through our network of approximately 80 support groups that are volunteer run across the country for both adults and kids, where people can connect with others in their local communities, learn about local resources, restaurants, foods, just share experiences, gain support. The second is our food safety programs. The first of those is our Gluten-Free Certification Organization, or GFCO. This is a program that certifies tens of thousands of products in countries around the world as gluten-free. We have a very rigorous and in-depth certification process. And so this allows consumers to easily identify and choose gluten-free products that they can have a high level of confidence in. Our other food safety program is the Gluten-Free Food Service Validation Program, or GFFS. And this program works with food service establishments. So that's restaurants, but not only restaurants, also assisted living facilities, university dining halls, hospitals, even food trucks, and meal delivery programs. So with these organizations, we go in, we work with them on how they train their staff, how their kitchens are set up, look at their ingredients, basically look at everything that might affect their ability to serve safe gluten-free food and help them be able to do that. And then the third final sort of general pillar to how we make life easier for people living gluten-free is through education. We provide education and information on many, many aspects of gluten-related disorders and living gluten-free. We do that on our website at gluten.org. There's a vast selection of educational bulletins, articles, a blog, resource pages for different groups such as parents and teachers. We publish magazines, one specifically for kids. We provide a lot of education on our active social media networks. We reach out to other groups and individuals who can help with this mission. For example, we recently participated in the annual meeting of the National Association of School Nurses, where we reached over 1,000 school nurses with information about what gluten-related disorders might look like so that they could steer students and families in the appropriate direction. And then finally, through a variety of other events, such as this one. This one is a great example. So now I would like to introduce our speakers. If you could just raise your hand, perhaps when I introduce you, that would be great. So we have Peter Green, MD, who is the Phyllis and Ivan Seidenberg Professor of Medicine at the College of Physicians and Surgeons at Columbia University and Director of the Celiac Disease Center at Columbia University. He is a fellow of the Royal Australasian College of Physicians and of the American College of Gastroenterology. He has lectured on celiac disease at many medical institutions throughout the United States, as well as at national and international meetings. Thank you, Dr. Green, for being here. And we have Noor Zibda, MS-RDN. She is a functional and integrative dietitian and nutritionist, author, and speaker. She helps people overcome digestive conditions such as celiac disease through individualized anti-inflammatory food plans, nutritional therapies, and integrative nutrition tests. She also helps people with hypothyroidism, autoimmune diseases, other food sensitivities, chronic fatigue, headaches, chronic pain, and skin issues by addressing underlying digestive imbalances. Thank you, Noor, for being here. And we have Dr. Kelly Baker, who has been practicing naturopathic medicine in the Seattle area since graduating from Bastyr University with a doctorate degree in naturopathic medicine. With a clinical focus on digestive disorders, she spends a great deal of time working to educate her patients, writing articles and giving talks throughout the community. And here she is doing exactly that. She was diagnosed with celiac disease after college and has been strictly gluten-free ever since, which helps to inform her clinical interests and allows her to empathize with the lifestyle and dietary changes that many of her patients have to make. Thank you, Dr. Baker, for being here. A couple of housekeeping details Elisa mentioned. Please keep your microphones and cameras turned off, and you may type any questions you have into the chat. We'll be compiling those during the session, and we'll get to as many as possible during the last approximately 15 minutes. Would like to remind you that this is general educational information, not to be construed as medical advice or a diagnosis in any form. This is educational information that you can take to your personal healthcare providers as a point of discussion. And now I'll introduce Elisa Sherman, once again, my co-moderator. She is a communication specialist at GIG, and I think we'll get going.
All right, thank you so much, Lola, and thank you to all of our speakers today. I'm going to start with a basic question, and I'm going to direct it to Dr. Green. I have what I've been told is gluten sensitivity, have not been diagnosed with celiac disease, but I react to gluten. Could you explain to the audience the difference between celiac disease and gluten sensitivity?
Sure. Thank you. And thank you very much for involving me in tonight's session. I've actually been working with GIG for about 35 years, attending many conferences. And certainly it was interesting to note that you said it's been around for 47 years. Certainly GIG has helped a lot of people in all that time. So I run the Celiac Disease Center here in New York, and we have 5 adult gastroenterologists and 3 pediatric gastroenterologists that look after people with celiac disease and other gluten-related disorders. And I think it's very important to establish the diagnosis of celiac disease correctly. Celiac disease is an autoimmune condition that's associated with increased mortality and increased morbidity. Getting a diagnosis is very significant because what happened then?
Uh-oh.
Peter came on, someone. You know, there are a lot of connotations to being diagnosed with celiac disease, you know, that include this morbidity business and association with other diseases and significance for other family members. And we know a lot about celiac disease. We know more about celiac disease as an autoimmune condition than we know about any other autoimmune condition. Like we know the genetic markers, we know the environmental precipitant, whereas we don't know that for type 1 diabetes or autoimmune thyroid disease. So we know a lot about it. And it's interesting, about 25 years ago, all the experts around the world in celiac disease said, you know, like, what's this business about people coming forward and saying, I have gluten sensitivity? Because typically gluten sensitivity is a self-diagnosis. People have a bunch of symptoms. They find that if they withdraw gluten, they feel better. And if they then introduce gluten, and all the studies that have been done have shown that it's not gluten. It's one of these FODMAPs. It's in the fructans that actually causes symptoms. That's if you take a group of people who self-identify as being gluten sensitive and do a double-blind study of gluten or fructans, it's the fructans that cause the symptoms. So, you know, that's very interesting. Now, on the other hand, we got a bunch of serum from a patient population in Italy of doctor-diagnosed gluten-sensitive individuals and found actually that there were changes in intestinal permeability that were not present in celiac patients, but they were present in these people with gluten sensitivity. So it's really not clear. It's not understood really what the condition is. like we love seeing people here with gluten sensitivity because we want to make sure that they're on a healthy diet that's varied and nutritious for them. And many people on a gluten-free diet are not on a nutritious diet. So we know a lot about celiac disease and not very much about gluten sensitivity.
Dr. Green, I think this is one thing that I know we want to get to and that people wonder about, and we hear this question quite a bit. What if someone, has self-diagnosed and they, as being gluten sensitive, they're on a gluten-free diet, they feel well, but as you just mentioned, it may be important to know if you actually have an autoimmune disease or not, but they haven't been tested for celiac disease. Should they be tested and why? But what about the fact that they have not been eating gluten?
Well, it's thought that maybe about 20% of people who self-identify as being gluten sensitive probably have celiac disease. So people come along here and they say, like, I know I'm gluten sensitive, but I want to find out if I have celiac disease. Some people say, I don't care what you're saying, I'm not going to eat it again, but I'd like to know. So we would always do the genetic testing because if people don't have the genetic markers, it's very, very, very unlikely to have celiac disease. And then if that's present, we would then offer people a gluten challenge, which is like 1 slice of bread a day for 3 weeks and then an endoscopy to see if they have celiac disease.
Yeah.
Often you can tell if people have celiac disease by asking what symptoms they get if they get gluten. There are very specific symptoms of people who maybe had no symptoms to start with, got diagnosed with celiac disease, went on a gluten-free diet. If they get exposed to gluten, they get nausea and projectile vomiting. If people get that, I think, well, I really think they have celiac disease.
Yeah. So I was thinking, Dr. Baker and Noor, both of you will see people at different stages of trying to find out what is wrong. And your approaches could lead to sending them to the gastroenterologist to get tested. But maybe if each of you take a moment and explain what you see and what the next steps you would take to send them for this testing. Because basically what we're trying to explain is, what are those steps? They have come in with symptoms, they're confused, they may have been misdiagnosed, but what are the things that might lead them then through that process of getting a proper diagnosis? So maybe start with Dr. Baker.
Thank you. So the bulk of my practice is probably patients coming in going, either I've already pulled myself off gluten and I feel better, now what is wrong with me? Or it's people coming in saying, I have symptoms, I'm afraid you're going to pull me off gluten. And so, a really big part of it is trying to tease out, is it celiac disease? Is it non-celiac gluten sensitivity? Is it something else entirely like small intestinal bacterial overgrowth that responds well to a low FODMAP diet, et cetera? And so as a primary care doctor in the state of Washington, a lot of times I'll start with genetic testing or even doing, some of the blood work for a celiac screen before I then say, okay, yes, it's positive. Let's send you into a gastroenterologist and get a confirmatory endoscopy. If they're eating gluten consistently, obviously we can do the latter. Many patients come in though, and we have the conversation then about, okay, is there a way to actually evaluate whether it's non-celiac gluten sensitivity or whether I have gluten intolerance? And so that conversation then can go a number of ways. Sometimes it's great, let's send you to a nutritionist and we can do an elimination diet. And then sometimes it is, there are various types of testing, I'll call it less traditional testing, that is available, like IgG and IgA ELISA assays, which are a bit more hotly debated with the medical community. And then there are, even other aspects of some antibody testing now with, as Dr. Green mentioned, some of the intestinal permeability and leaky gut, where we can start to make determinations on whether it looks like there is damage due to a food sensitivity be it gluten or something else, whether it's damage due to an autoimmune disease, or whether it's damage due to a microbe or a microbial overgrowth in the gut that is not food related at all.
Interesting. And Noor, what about you? You see patients with all kinds of different kinds of digestive disorders, but celiac disease doesn't only show digestive. But what are the kinds of things you see?
Yeah, and kind of my situation is like Dr. Baker, is that it's either they've heard of a gluten-free diet because, you know, people are reading and surfing the web for answers. And so they either tried it, and then sort of my job to see, did they really try a strict gluten-free, or is it a low gluten diet? And just to explain that eating, you know, still eating a piece of bread or a cookie once a week is not considered a gluten-free diet. And so some of them have already tried it, and some do eat gluten and kind of also afraid of like, okay, well, what are we going to do? And a lot of them are in pain and they're uncomfortable. So they're actually motivated. So I always, you know, if they have done that workup, like the celiac disease panel before coming to me, it definitely makes it easier, because then if it's negative, then we can just move forward. And if they haven't done it, and I feel like it's, this could be a possibility, I think it's always important for anybody listening is always get that celiac disease panel done before you try a gluten-free diet on your own, because if you feel better without gluten, it's going to be really difficult for you to come back. You may not want to ever have gluten again. And then you won't know, for the reasons that Dr. Green mentioned, it's the autoimmune aspect of it, how it can affect your family, you know, your children or siblings or things like that. So kind of the same approach is testing is always important. And then, you know, there's all the FODMAPs aspect, the SIBO, a lot of these diets do respond to removing gluten, and we're going to say bread because it could be the fiber or the gluten component. And I often tell my patients, listen, I'm going to remove bread from your diet, so why don't we get the test done first? And I'll send them back to their doctor and try to get that done before we do any intervention.
Interesting. Just a quick sort of logistical question for people who might be wondering, the celiac blood screening test, is that something that a person's primary care doctor can easily order, or does somebody need to see someone who's more geared towards digestive issues?
Anyone can check the box
Yeah.
for a lab test, and but the interpretation has to be done correctly.
Okay.
It can be very confusing. Like there's a celiac panel, a super celiac panel, a deluxe panel, and it's confusing. I personally use the gliadin peptide IgA and IgG and the TTG IgA. But because you do see people, often the panel has a total IgA, and I've seen people told they have celiac disease based on a total IgA level.
So a person could discuss with their primary care and have the test ordered, but they really should be interpreted by somebody who's knowledgeable about these issues.
And with all of this stuff, you know, you have the result, it's electronic, it's on paper, it can be transported to your dietitian, to your doctor, can be sent around the world. So no one's got any proprietary ownership of any specific except the patient.
Yeah.
Go ahead.
No, I totally agree with Dr. Green, because a lot of times, you know, patients are told, whether it's for celiac or something else, like, you're fine, the doctor doesn't call them back, or they're just left waiting. And I always tell them, take a look at the result and see what it is, because interpretation, like, were you eating gluten or not? You know, what about those borderline ranges? And I think it's really important to discuss with the provider, whether it's the person who's ordering the test, or if you have working with, you know, additional providers who are helping you look at the big picture and what that could mean for the person.
And I'll say, fortunately, I'm starting to see, and I'm sure this is the case for all of us, that we're starting to see more and more primary care doctors either be willing to run a celiac panel when asked, or they're coming up with that idea of their own volition. And so I have more patients that have had come and say, well, we've ruled out celiac disease, or as best as we can, so far. So now what?
Yeah, that's great. One thing I wanted to bring up related to this as well is, we know that for celiac disease, someone needs to get a diagnosis. You need to be consuming gluten. You need to have the genetic predisposition. But we also know that not everyone that meets those two criteria is going to develop celiac disease. So what is the third factor that might lead someone to develop celiac disease? An environmental factor, right?
It's interesting. We're very much aware that over a 50-year period, celiac disease increased about 5-fold, okay? And that increase was mainly in the 70s and the 80s. And we don't know the reason for that. There are known risk factors, like some of the risk factors are getting a GI infection, like rotavirus. The troops that went to Iraq and Afghanistan and got Campylobacter gastroenteritis, they showed an increased risk of having celiac disease. There's reovirus. Today I saw a young woman who had very bad COVID, and she got like this POTS syndrome and a heart issue, and then about six months later she came down with celiac disease. So I wonder if we're going to have like a post-COVID celiac epidemic. Wow. Like there are other drugs that increase the risk, the use of PPIs, proton pump inhibitors, the use of antibiotics. Like this increase in the 70s and the 80s, that was really coincident with widespread use of antibiotics. Mm-hmm. And then there was a large influx of this vital gluten as well. And we don't know how much vital gluten is put into food products, but you've got to be eating gluten, and 98% of us do this. You've got to have the right genes. 40% of us have that, but only 1% get celiac disease. Right. So it must be environmental factors and or other genetic factors. Yeah. Within a family, the genetic factors are probably predominant. Yeah. But we're actually we've got like a company that's going to do whole genome screening of involved families. So if people have like more than one or two family members, they're ideal for finding these other genes. But while we know a lot, we don't know everything at all.
Yeah. So in terms of a non-celiac gluten sensitivity and celiac disease diagnosis, we've already touched on the fact that it's really sort of an amorphous definition when it comes to non-celiac gluten sensitivity. But is there any indication that someone who has non-celiac gluten sensitivity, thinks they are sensitive to gluten but don't have celiac disease, will progress into celiac disease? Is there a continuum there at all?
Well, yeah, Kelly?
What I was going to say is my experience is that we with someone who is concerned about that, I'm going to ask about their family history. Do they have anyone else in their family with celiac disease? Do they have the genetic propensity to have those things? And I'm not familiar with specific research studies on this, but it's been my experience that no would be my short answer.
Not unless they had it to start with.
That's exactly right. Unless it was misdiagnosed. That's exactly what I was going to say.
Yeah, I when I listen to this, I'm so fortunate to be part of GIG and to be able to hear directly from experts like you, because I'm always identifying the fact that I've been told gluten sensitivity, or I've assumed it, stopped eating gluten 15 years ago, haven't had any issues since, could actually mean that I had celiac or have celiac disease, but I'm on a completely gluten-free diet. So how would I know? But why shouldn't
so it doesn't matter really to you, does it? It doesn't really matter to you.
But it does. I have a child, and so I would be worried about her. So as a mom,
that could put the burden on you to really prove you don't have celiac disease.
Right.
Because otherwise you might infect your children with the idea that they also are gluten sensitive. because
they will not stop eating gluten no matter what. No matter what. But
you could always try to prove it.
Right. And I could. And that means going back to gluten. And it's so interesting, too, the idea of going back to gluten and some people being adverse to the idea of doing that. Well, some people get extremely sick. My reaction is a little more limited. So if you told me I had to eat a lot of gluten, I'd almost, if
but
it's
you
part
don't
of,
have to eat a lot of gluten.
That's what you were saying. So what is it that you have to do?
We used to say like 3 or 4 slices of bread a day for 3 or 4 months and that. But it's been shown that like 1 slice of bread for like 2 weeks is enough. There will be a test coming out soon in which people have like gluten over 3 days and then get a blood test. You know, there will be that available soon. And that came out of the work of the people who did the vaccine study. It didn't work.
And is it the case too that until the time when that comes out, which will be great, that the sort of amount and length of time over which a person would need to reintroduce gluten could also depend on how long someone's been gluten-free? In other words, sort of how healed they are?
No.
Or is it not related?
It does not appear to be related.
Interesting.
Like that small amount of gluten for that shorter period of time will pick up 80% of celiacs. So, you know, if people are tolerating it, you can get them to go longer to maybe get that 20%. But, you know, it's not like it, you know, then people give up, which is understandable. You know, if they get sick when they eat gluten, you know, people don't want to do it. And that's very understandable. So it's just very important to take those patients and to look after them. Like there are some people who say, I don't want to look after you. If you can't do the thing that I want you to do, it's like you can't do anything about it. You know, physicians shouldn't do that. They should like accept the patient for what they are.
Yeah. So turning to a slightly different track, I'm also interested, Noor, in asking you, when you are seeing patients for, you know, other food sensitivities, whether you sometimes uncover the fact that gluten is an issue and when they have not really been aware of that, does that arise?
Yeah, I mean, a lot of times people come to me and they have gas or bloating or diarrhea and they really don't know what's going on. And we are trying to find out what the triggers are and what's going on. So I run some tests as well with my patients. And so if it's something, you know, I would like for them to get the gluten test done or the celiac disease test done, we can identify some food sensitivities as well. And so over the years, I've had patients say they've gotten actually worse when they gave up gluten. And turns out they're eating a lot of corn or rice or quinoa or almond butter. And there could be other things that are causing their symptoms. So the gas, bloating, diarrhea, constipation, the nausea, they could be related to SIBO, small intestinal bacterial overgrowth, or they're still eating a lot of sugar and there could possibly be a candida or yeast issues, or they could have sensitivities to the alternatives, or, you know, eating a lot of nuts. We have oxalates and we have like salicylic acid and histamine and all these components in food. It's not just gluten and celiac. And so I run a food sensitivity test for almost everyone I work with. Many times they've already dabbed into the FODMAPs or have done something. And, you know, we kind of talk about like how well, like did they do the diet properly and in order to assess if it's working or if it has worked or not. But many of them are and we are ready for the next step for uncovering this. And it's kind of interesting. Like I do have many patients who discover maybe it's rice that's the problem, and switching to a gluten-free diet has a ton of rice or corn or something like that. So I think it's really important to not vilify gluten and always assume it's celiac, because it could be all the other things. And sometimes there are things that they can do. Because a lot of times people ask, like, can I fix this? Is this problem reversible? You know, if it's celiac, it's celiac. And unfortunately, it's an autoimmune condition, and they're always going to have it. But if it's not, and if it's like a fermentation issue or IBS or SIBO, well, we can actually manage it with diet and lifestyle, and maybe avoiding certain foods or elimination plan, or working on repairing the gut and digestion and things like that. So yeah, it's like sometimes I know what I'm up against, and sometimes we're discovering this as we're going.
Yeah, I think it's.
Could I make a comment, Noor? Like, I think that's a very good point that you raised, because it's not uncommon for someone to not have many symptoms, get diagnosed with celiac disease, and then get a lot of symptoms. And, you know, it's like people coming in saying, like, I'm eating really healthy, but I feel terrible. It's this eating really healthy with the FODMAPs and the fruit and the vegetables and excessive fiber when they're not used to it. So that's why I think it's very important that nutritionists are aware of this, and like the pitfalls in people changing their diet dramatically. You know, it's often just not tolerable.
Yeah, and like people sometimes, especially if they have diarrhea or constipation, they are trying to add more fiber to help with either conditions, and more fiber and more vegetables and legumes and grains actually make them feel worse. And that's often a red flag. I ask patients, does eating healthy make you feel worse? And if that's the case, or you feel worse at the end of the day after sort of the accumulation of meals and snacks they've had, then maybe it's a fermentation or SIBO issue and not as much, you know, celiac disease. So asking these questions is really important. And, you know, it's in the details. Like the details are what really important part of what we do.
Yeah, it's interesting. I think just because over the last, 5 to 10 years, the awareness around gluten has increased so much that, there are some people out there, as you have all said, that just sort of decide that it must be gluten. And clearly it is gluten for a lot of people, but not for everyone. So it's really important for people to, thoroughly have their own situation assessed in consultation with their healthcare providers. One thing we want to make sure to get to, and Dr. Green, I think you're the one that can speak to this, is what is involved in an endoscopy? Because a lot of people, hear that getting an endoscopy is the gold standard for diagnosis, but what the heck is it? And what's involved?
I can tell you it's easier than a colonoscopy for both the performer and the performee. It's people are sedated, and a tube about the diameter of a pencil is passed down through the esophagus into the stomach, and pieces of tissue are taken, little 1 millimeter square pieces of tissue are taken from the duodenum. It's usually tolerated very, very well. Something that I'd like to comment on is you have a whole bunch of people that get diagnosed with celiac disease, and they're going to have the diagnosis forever, right? Because we believe you don't grow out of it. And you see some people they never had an endoscopy, which there are pediatric guidelines in Europe for making the diagnosis without an endoscopy in a child. But it's very important that guidelines are followed. If someone does not want to have an endoscopy, the guidelines are that the blood test, the TTG, is like 10 times normal, and then it's repeated with another blood sample. And there are two reasons for that. One, you can have this temporary gluten autoimmunity, and two, they could have screwed up the bloods, and it could be someone else's blood. So if the diagnosis is going to be made, it should be made according to guidelines. Otherwise, it'll always can be doubted. It's not uncommon to see people who grew up being told they had celiac disease and they actually didn't have it. It makes to very angry young people, actually.
Yeah.
So it's an important diagnosis to make, and it should be made along specific guidelines. And the guidelines change, but that's fine. You know, there were guidelines way back when I started of having 3 endoscopies. And then when the blood test came in, you can have 1 endoscopy. And now the blood tests are considered to be very good, but you've got to have the right numbers and the number of tests. But an endoscopy is like nothing is totally without complications, but there are also complications of being labeled as having celiac disease and not having it. So,
and I've had a number of patients where we'll run a blood screen and their antibodies will come back either borderline or just barely positive. And if, you know, someone is super hesitant about an endoscopy for whatever reason, and we ask for a follow-up blood test, the next time they have their blood run, it's totally negative.
Well, they might have cut the gluten out.
But that's obviously possible, but I always, you know, guide them not to.
Yeah, well, I've been very interested in this potential celiac disease, which is positive blood tests and a negative biopsy. Like there was a big study out of Italy that took 300 children with this potential celiac disease, and like they had a negative biopsy, and then following them up for 12 years, a third of them lost those antibodies, a third remained the way they were, and a third went on to develop celiac disease. So I often wonder, like, what happened to all those individuals that I saw years ago and said, I don't think you have celiac disease. You know, because like the standards change. So it's very important for people to keep up, you know, with the literature actually.
Yeah, so lots of questions. And, you know, this makes me wonder about, for instance, in a family, this has come up, if there is a family member who has celiac disease and other family members are wondering, or a parent is wondering about their children, you know, how often should they be assessed or screened? I'm sure that varies by individual, but are there any sort of...
Yeah, well, excuse me, I don't want to, but so what we do is we give the family cheek swabs. And they go and they do cheek swabs of the other family members, especially the children, and you find out if you've got the gene, right? So there's no blood stick available. They can do it from day one. And then if they have the gene, they're then advised to be screened with a blood test maybe every 3 to 5 years.
Okay.
Not every year. But doing the cheek swab, I'm very surprised that more pediatricians don't do that. You can do the cheek swab, it goes off, and then you get the result whether they've got the at-risk genes or not. And within a family in which there are family members, at least 20% won't have the gene. So that's the step that we do.
Yeah, that's interesting to hear that it's so easily done. Huh.
One of the challenges that I've had with ordering the cheek swab is that insurance tends to give a lot of pushback. So I've had to follow up as the physician and write a lot of letters and, you know, document support, and that there has been a member of the family who does have diagnosed celiac disease in order to potentially get it covered, which makes it a bit more challenging than sometimes the blood work can be.
Like the company has worked with us and putting in the right ICD codes. We don't get a problem, actually.
Good.
So
actually, if we start looking, oh, go ahead, Nora.
No, I was going to say, as a mom of young kids, I mean, this is so amazing. Like, it's like taking your kids, your 5-year-old or your 3-year-old to get blood work done. It's like a nightmare. So it's such a relief for moms, because I'm seeing some of the questions, and like we have a lot of people who are here for their kids, and I mean, it's, you know, we want the best for all of our kids, and so this is great.
Are we allowed to comment on the questions?
Well, we were just going to get to the questions, weren't we, Lola?
Yes, I think it is exactly that time. So
yeah, we've copied all the questions into a document and are organizing them by category so we can try to get to as many as we can. So, and the first question that we were going to get to was, does the GI doctor do the genetic testing? And you just organically began to answer that. Is it true then that any of your health practitioners could order it, but as Dr. Baker said, there could be an insurance issue, but who can order that if the genetic testing? And is it just that cheek swab, as simple as that?
Yeah, it's very important that if people are going to get the genetic test, that they understand what it means. That they understand that it does not in any way mean that anyone's got celiac disease. We just did research with 23andMe and found that 39% of the US population are DQ2 or DQ8 positive. So it's 40% in the United States. So all it does is signify there's a risk. And I tell people the value in doing the genetic test is if it's negative, because then it's very hard to have celiac disease if it's negative. So one's got to understand, and then anyone can order any test, but it's the interpretation that's very important.
So you also, another question is about the specific blood test that's done. And I believe that you mentioned a few of the things that you look for when the blood test is done, but could you explain a little bit further what you're actually looking for in the blood?
You know, pediatric gastroenterologists use different blood tests to adult gastroenterologists. Like as a celiac GI doc, we do TTG-IgA, tissue transglutaminase, gliadin peptide IgA and IgG, and would typically biopsy anyone who's positive in any of those. We may throw in a total IgA to see if someone's got selective IgA deficiency, but don't routinely do that even. So that's what we do to diagnose celiac disease, and then suggest an endoscopy if they're positive. Now, if they're very low levels and only a gliadin antibody, we know that maybe only 10% of those people will have celiac disease. We'll say continue to eat gluten and let's repeat it again in 6 months if you don't have a lot of symptoms. If one's got a lot of symptoms, that would push you along. But, you know, many people come along and say, my doctor did these blood tests, he said, come along here, but I cut out gluten like 3 weeks ago or 4 weeks ago. So now that's not enough time for things to normalize, but it's an inclination that is quite understandable, but people should be advised to not do that.
Someone else is asking, what about if your provider refuses to give you a celiac test or to administer one to your child? Is that often the case? And if so, what would you recommend? Dr. Baker, if you would answer.
Yeah, every once in a while I'll have someone who actually will come to me and say, my kid's pediatrician wouldn't test them for whatever reason, you know, can you run the test? And what I would say is talk to a different doctor. You know, if you're unsure, you know, but getting, as Dr. Green and Nora both mentioned, having it done by a doctor who knows what they're going to do with the interpretation is much more relevant than just having a screening done, or taking it after it is run to a doctor who knows what they're doing.
Yeah, I mean, totally agree. I, as a dietitian, because I don't submit to insurance and I have access to a lot of testing, and my patients have access to a lot of testing, and I think it's really important to you know, understand and like work in collaboration. So I work alone and I, you know, and on my own, but it's important to, you know, the GI doctor has an important role and your primary care can help you as well. And the dietitian is going to look at different aspects, but there are tests that may or may not be very useful. And so I think it's really important to look at what are you going to, like, what information are you getting? How are you going to apply this test? How are you going to use it? Is there someone helping you interpret it? Because with all the information that's available and the access to testing, that can be good and bad and can also create overwhelm and a lot of resources being spent on maybe not the right places.
And Dr. Green had mentioned 3 different antibodies that they traditionally test for in their adult suspected celiac patients. And the basic celiac panel for most of the labs just consists of one of those antibodies too. So, you know, again, knowing a practitioner who is more familiar with kind of the scope of what testing should be, There's also a comprehensive panel that has 5 things that maybe now we realize aren't all necessary or are redundant. Yeah, it's redundant. So, you know, that again, having a physician who's familiar.
Yeah, there was a question there about, like, all my family went gluten-free. You know, that's very, like, it's kind of an admirable thing to do at the start, but it is probably not advantageous to the health of the whole family. You know, unless a gluten-free diet is advised by Noel or by an experienced dietitian, we think that it's not a very healthy diet. You know, like our studies showed there was increased diabetes and increased heart disease in people who didn't ingest much gluten. So it's just not a good idea for everyone to be gluten-free in the household. One understands it because preparing food, etc., there's great inconveniences in that, but it's just probably not a great idea, you know, for everyone to be gluten-free in the household.
I think that's a really good point to make, because so many people are just simply going on gluten-free because they hear about it and somebody said it made them feel better, and making those kinds of choices without an expert like your primary care provider or like a dietitian like Noor. Sometimes you take the information you get from the internet and you're self-diagnosing and you're self-treating, and it may not work out very well for you or your family. Here's a question. Oh, yeah, go ahead.
No, that's okay. Go ahead.
Oh, well, somebody said I have a biopsy that confirmed I have celiac diagnosis, but I don't have GI symptoms when I eat gluten. I think people are a little confused if they don't necessarily have digestive systems and yet have celiac disease, wondering if microscopic amounts of gluten or gluten from cross contact would be affecting them if they don't feel sick.
The majority of people with celiac disease don't have GI symptoms. You know,
interesting.
You know, our study of like 2,000 people a bunch of years ago, only 40% had GI symptoms at diagnosis. And they're the ones that are diagnosed. So the ones that are not diagnosed more than likely don't have GI symptoms. And often people don't get symptoms when they eat gluten until they've been gluten-free for a couple of years. But you just can't use the fact that you don't get symptoms to indicate that you don't have inflammation going on. Like, we don't know how much gluten any one individual needs to get the immune reaction going. Like, I know that some people appear to tolerate like a little bit of gluten without it causing inflammation even. But any individual can't tell that, you know, and you can't use the oral test of I feel okay as an indicator.
Interesting. We have a question here. Speaking of symptoms, dermatitis, herpetiformis, the skin rash that can come with celiac disease. This person has said that they've heard some people who don't have celiac disease have this particular rash. And is it a signal that you have celiac disease, or is it possible that it could be something else?
We regard dermatitis herpetiformis as celiac disease of the skin. Everyone has a gluten sensitivity, but 20% of those people with DH don't have an abnormal biopsy. So you diagnose DH from a biopsy of the skin, and you don't really need a biopsy of the gut, because if it's a true positive in the skin, you got celiac disease and you have the same risks as people who have the GI involvement.
And another thing too about symptoms, there are so many symptoms that may not be celiac disease, that could be other things. What are some of the other things, like Noor and Dr. Baker, what are some of the other things that you see the symptoms and it turns out to be something other, like what are some other autoimmune disorders or things that it could be? You mentioned the FODMAP, but other things as well.
Or you're welcome to start.
Well, you can go ahead.
So from a digestive perspective, Noor actually mentioned several of these earlier, whether it's small intestinal bacterial overgrowth, we'll see symptoms that can present as digestive symptoms that get worse throughout the day as you eat. I tend to experience when food sensitivities tend to be more of the trigger, symptoms tend to come on either more in the morning or right after eating each meal. I also see a number of fungal or candida overgrowths in the gut, particularly if someone's symptoms are onset after, a large round of antibiotics or, treatment for a sinus infection, something like that, we'll tend to see more of a fungal overgrowth. And symptoms for those are going to be gas, bloating, diarrhea or constipation. But I even see headaches and fungal rashes on the skin and, other things that can also be associated and make me think in those directions. Irritable bowel syndrome is another kind of catch-all term that means all the symptoms that aren't anything else we know what it is. And I know that, hopefully a patient at that point has had other things ruled out from their gastroenterologist, like celiac disease, like ulcerative colitis, like Crohn's disease, which are some of the other digestive autoimmune conditions that a gastroenterologist can rule in or out with a colonoscopy. And those symptoms tend to have, or patients tend to be, in some cases more severe, in some cases have no symptoms at all, but more likely to have things like blood in their stool, which is less common with things like small intestinal bacterial overgrowth or IBS.
I kind of also wanted, maybe not necessarily answering the question, one of the things that, I would make people to pay attention to is, if you have canker sores, if you're always anemic, and sometimes people tell me like, I do eat meat, I'm not on any restrictive diet, but I'm always anemic. And just kind of, they mention it casually. And sometimes it could be another malabsorption issue. It doesn't always have to be celiac, but sometimes those comments is what helps me say, you know what, this is really important to rule out. So sometimes it's not always in the gut. The gut can cause a lot of brain fog and skin issues and fatigue and aches and pains and things like that. And so, sort of it's like a blessing if you have digestive issues, because that motivates you to actually do something about it and seek a diagnosis. But a lot of times it's systemic, and it's really important to make those connections.
Right, because isn't non-responsive iron deficiency anemia is one of the more common presentations of celiac disease in adults, isn't that right?
Iron deficiency anemia at any age, in any gender. It was always taught in medical school that if you're a female and you're menstruating, that's the reason for iron deficiency. But in fact, celiac disease occurs, as we know, in both genders and at any age. So it's very important that people who are iron deficient get tested for celiac disease, irrespective of those.
Yeah. Do we have time for just another question or two, Aliza? I think we need to wrap up pretty quickly.
Well, I was thinking we needed to wrap up. We do have so many questions, and I would propose, because there are so many questions, maybe after this session we can organize them and then maybe turn to our experts for a couple of quotes and then put this on the website as a follow-up blog post where we can really address some of these other very particular questions, since we are running to the top of the hour.
Yeah, I think that's a great idea. And all right, well, we thank the three of you very much. Noor, Dr. Baker, and Dr. Green, this has been really informative. Thank you all for attending. Just reminding you all that this has been recorded, so you will be receiving a link to that, and we'll determine how to let people know to look for answers to some of these other questions as well, or just check back on our website. And I think that's it for tonight. We're just about at the top of the hour. So have a good evening. And thanks again very much to our panelists. And thank you all for attending.
Thank you. Thanks for having us.
Thank you very much.
Thank you.
Bye-bye.
Thank you.
Bye-bye.